question is, ma'am, if possible, say about thin endometrium management, ma'am. Okay, so thin endometrium, this is a it is a problematic thing for especially patients when you're preparing them for embryo transfer. What we should do for thin endometrium is, first of all, we have to assess thin endometrium. We should know why this thin endometrium is happening. Either it is because they had history of tuberculosis before, or they had any multiple DNCs done before. It's called as iatrogenic thin endometrium, where because of the multiple DNCs, they might have this thin endometrium. So such patients, we try to give them vitamin E. We try to give them vasodilators. We can give them RG prime. We can give them sildenafil tablets vaginally to improve the blood flow. We can give them ecosprin to improve the blood flow, and try giving a HRT with estrogen, estradiol, valrate. We can give them. There are three modes which we can give them: either oral, vaginal, or we also have estrogel. So we have to give them, try improving the endometrium with this estrogen when we're doing a HRT cycle, when we're preparing the endometrium for embryo transfer. So somebody who's not improving with this all modalities of estrogen and also these vasodilators, then we should move on to the next step of trying to give them granulocyte colony stimulating factor flush. We do this flush inside the uterine cavity. So this helps to enhance the endometrium and helps to grow the endometrium. If still they're not responding with this granulocyte colony stimulating factor GCSF flushes, we have to give them a flush and assess the endometrium and see after 3 to 4 days, we see how they're responding. If they're responding well with these flushes, then we can continue doing that, and we can, wait till the endometrium grows up to 7 or 7.5, because somebody who has very thin endometrium, we cannot expect them to grow up to 10 or 11, or at least if we get 7.5, if they're crossing 7.5, we should be happy about it. But still, if the endometrium is not responding with your GCSF flushes, now we're doing this advanced platelet-rich plasma with uterine instillation. Even the PRP has good results we are seeing with PRP to improve the endometrial thickness. And still, if the patient is not improving with intrauterine PRP installations, then we should think of hysteroscopic PRP installation, where we inject the PRP into the basilar layer. This is needed for especially for those patients who had iatrogenic thin endometriums, where the basilar layer is scraped up during the DNCs. Somebody who's had multiple DNCs and now they're having a thin endometrium. For them, this hysteroscopic PRP installation would help. So these are all the protocols, these are all the modalities usually we are doing. And also these days, there is a recent, protocol where we do with low dose HCG and also growth hormone. This is a recent, there are many studies coming up, and we are also seeing good results with this. We are also seeing patients who become positive and they delivered with very thin endometrium doing this HCG and growth hormone protocol. So there are various protocols depending on patient to patient. We see how they respond, and then we have to move on to the next step. And this is how usually we deal with thin endometrium patients.
For more information and updates, subscribe to Oasis Fertility. Hit the bell icon for future notifications.